Hi, my name is Mary Vukicevic, and this topic is about the surgical treatment of glaucoma. So far, you should have an understanding of the medical treatment for glaucoma in terms of medication and topical medication and drops, and we've also covered laser interventions. But when is surgery used? Well, basically, surgery is considered if glaucoma continues to progress and get worse despite the fact that the patient has had the maximum medical therapy or laser therapy that they can have. There are three types of surgery that are performed, and they are designed to lower intraocular pressure. And they do this by either draining aqueous out of the eye or by cutting into the iridocorneal angle to help lower the intraocular pressure, or open up the angle for better access of the aqueous to the trabecular meshwork. They are really a last option, and they are invasive, and they can also cause cataract. So they're not a preferred choice. The preferred choice that you would start a patient on in glaucoma management is drops. Let's take a look at the first type of surgery, and that is a trabeculectomy. Trabeculectomy is what we call a filtration or a drainage surgery, and it lowers intraocular pressure by creating what's called a fistula, and the fistula is protected by this flap of sclera superficially. And what it does is it allows aqueous to flow out from the anterior chamber into an area called the subtenon space. The schematic diagram shown here from Kansky is an image of the actual technique. And so what the surgeon does is he or she creates a flap into the sclera, and a small section of the peripheral iris is removed. And this creates the drainage area. And so what ends up happening is intraocular pressure is lowered because aqueous is diverted out into this fistula. The fistula we also call a bleb, and the aqueous ends up in the extraocular veins and lymphatic system. So as I mentioned, trabeculectomy ends up leaving a patient with a fistula or a bleb, and the image on the top left shows a normal looking bleb which is located at the superior limbus. Usually you'll find that if you just raise the patient's eyelid a bit. And the bleb itself is white, and it's also slightly raised, ever so slightly, and it allows the aqueous to flow out. Now, the bleb shown on the top right hand side is flat. You can see it's not really raised like the one on the left, and actually this is a non-functioning bleb. The lifespan of a bleb after about 5 years is reported to be about 80%. So actually after that time most of them do continue to work. The bleb on the lower left side is vascularized. You can see it's still raised, but it's very red and injected. And the one on the right hand side on the bottom right has a cyst under it. And these two on the bottom are not normal looking blebs. And of course the one on the top right is not a normal looking one. So have a look at the one on the top left. That is a normal bleb, and that's what you should be observing in your glaucoma patients when you slightly raise their lids, these normal looking white, slightly elevated blebs. Now this is important because you will definitely see these blebs in your clinic, because there are patients around that have had to have trabeculectomy for whatever reason. In addition to trabeculectomy, patients can also have non-penetrating glaucoma surgery. And basically this is very, very similar to trabeculectomy, except it's also a filtration procedure. But the surgeon doesn't enter the anterior chamber like in a trabeculectomy, where they go in and they actually remove a little piece of the iris. So what happens here in the non-penetrating surgery is that the internal trabecular meshwork is actually preserved, and this will reduce the incidence of post-operative complications. So the image here shows what the surgery looks like, and as I said to you before, it is similar to a trabeculectomy, but the filtration area is created outside of the anterior chamber. The main indication for this type of surgery is primary open-angle glaucoma, and one of the things with it is that the reduction of intraocular pressure is not as good as what you can achieve with a conventional trabeculectomy. So the patient also then needs to continue with topical medication. So a trabeculectomy or a conventional filtration surgery is still therefore the procedure of choice. Now, I'm telling you about non-penetrating glaucoma surgery because you might see some of these things written in a patient's file, and there are 4 types of non-penetrating surgeries, and they are a deep sclerectomy, which is the picture that's shown here of the technique, a viscoanalostomy, canaloplasty, or a trabectome. So just keep those in mind when you go out on clinical placement, because you may see these may see trabectome written in a patient's file, and you'll know then that it's just a non-penetrating glaucoma surgery. So they're all the same in that they all basically create a filter where the aqueous can flow out of the anterior chamber, but they just have a slightly different technique, which is what gives them the different name. And the last type of glaucoma surgery I'm going to talk to you about are drainage shunts. Again, you'll definitely see these on clinical placement, and these are called glaucoma drainage devices, or GDD, and they create a communication between the anterior chamber and the subtenon space using a tube. So this tube is attached to a little section of reservoir which is placed posteriorly or to the side of the eye. And some of these tubes also contain pressure sensitive valves, and these help to regulate aqueous flow. So the diagram on the left shows a particular drainage shunt called a Molteno, and this was named after the man who invented it, and this is a very popular one. So you will again see patients with these Molteno implants. And what happens is the tube travels from the anterior chamber in the eye, and then it'll pierce the sclera and ends up externally into this drainage reservoir. On the right hand side, you'll see a picture of the Molteno implant in the eye of a patient, and you can see the tube just sticking out there in the anterior chamber on the top left hand side. Now the top little insert picture shows how that tube travels posteriorly. There are 3 commonly used shunts, and they are called the Molteno, the Bayervelt, or the Ahmed, and I suspect they're all named after the person that invented them because they're fairly new techniques, I guess. So these are mostly used in patients that have severe conjunctival scarring. They might have uncontrolled glaucoma despite previous trabeculectomy, for example. They could have secondary glaucomas like neovascular glaucoma, or if they've had a traumatic event to the anterior segment, they might have developed glaucoma, and a drainage shunt could be used in that instance. Or in certain congenital glaucomas where conventional therapies have been tried but they haven't been successful. So in summary, there are 3 general types of surgery for glaucoma: trabeculectomy, non-penetrating surgery, and drainage shunts. And what you need to remember is they're mostly used when conventional therapy has failed for whatever reason.